Vitamin D is a crucial nutrient that plays a significant role in maintaining bone health, promoting calcium absorption, and modulating immune system functions. It is synthesized in the skin in response to ultraviolet B, UVB, radiation from sunlight, and its deficiency is linked to a variety of health issues, most notably bone mineralization disorders such as rickets and osteomalacia. In the context of certain rare metabolic disorders that require patients to avoid sun exposure due to either the risk of exacerbating their condition or due to photosensitivity, the deficiency of vitamin D can become a serious concern, leading to increased risk for osteoporosis, fractures, and other musculoskeletal complications. This article focuses on the impact of vitamin D deficiency on bone density in patients with a rare genetic disorder, Xeroderma Pigmentosum, XP, which causes extreme sensitivity to UV radiation, necessitating strict sun avoidance. We will explore the pathophysiology of this condition, the role of vitamin D in bone health, and the challenges in managing bone density in these patients. The aim is to provide a better understanding of the intersection between genetic disorders, vitamin D metabolism, and bone health, while also offering insights into possible management strategies. Researchers in Rotterdam have tracked vitamin D supplementation improvements in bone mineral density among patients with erythropoietic protoporphyria. Erythropoietic protoporphyria, EPP, is a rare inherited metabolic disorder affecting heme biosynthesis, leading to lifelong painful phototoxic reactions starting in childhood. To mitigate symptoms, patients vigilantly avoid sun exposure by staying indoors or wearing sun-protected clothing. Minimizing sunlight exposure increases the risk of vitamin D deficiency, a known contributor to early-onset osteoporosis. Previous studies have shown that EPP patients indeed have a high prevalence of low bone mineral density, BMD, with osteopenia and osteoporosis rates well above those in the general population. Since 2016, afamelanotide, a synthetic analog that enhances eumelanin production, has been available to mitigate EPP symptoms and potentially increase sunlight exposure. However, its impact on BMD has yet to be previously studied. In the study, The Impact of Minimal Sunlight Exposure on Bone Health, Insights from a Cohort Study in Erythropoietic Protoporphyria, published in the Journal of Clinical Endocrinology and Metabolism, the team wanted to ascertain factors that affect bone mineral density, BMD, in EPP. The study included 139 EPP patients from the Dutch EPP cohort. Vitamin D status was measured through serum 25-hydroxyvitamin D levels. Researchers analyzed dual-energy X-ray absorptiometry, DEXA, scans of the lumbar spine and femoral neck to determine Z-scores for BMD. A Z-score compares an individual's bone density to the average values for a person of the same age and gender demographic. Patients with vitamin D deficiency who had not previously received cholecalciferol had the highest likelihood of BMD improvement with vitamin D supplementation, cholecalciferol. Treatment with afamelanotide did not result in significant BMD improvements. The high prevalence of osteopenia and osteoporosis in EPP patients underscores the importance of continuous vitamin D monitoring and supplementation. These findings also highlight how EPP can be studied as a natural model for the effects of minimal sunlight exposure and vitamin D deficiency on bone health, with significance to lifelong vitamin D sufficiency for the general population. Vitamin D metabolism and bone health. Vitamin D is essential for maintaining optimal bone health through its role in calcium and phosphorus metabolism. The active form of vitamin D, calcitriol, promotes the absorption of calcium in the intestines, regulates calcium reabsorption in the kidneys, and modulates the activity of osteoblasts and osteoclasts, the bone-forming and bone-resorbing cells, respectively. Vitamin D deficiency disrupts these processes and can lead to impaired bone mineralization, resulting in weakened bones that are more prone to fractures and deformities. In a healthy individual, vitamin D is primarily synthesized in the skin upon exposure to UVB light from the sun. However, in some individuals with genetic disorders or specific medical conditions, this natural process is impaired or dangerous. Xeroderma pigmentosum, XP, a rare autosomal recessive disorder, is characterized by a defect in the DNA repair mechanisms, leading to hypersensitivity to UV radiation and an elevated risk for skin cancer. Patients with XP must adhere to rigorous sun avoidance practices, including wearing protective clothing, staying indoors, and using sunscreen. Xeroderma pigmentosum and sun avoidance. Xeroderma pigmentosum, XP, results from mutations in genes responsible for nucleotide excision repair, NER, a critical DNA repair pathway that corrects UV-induced DNA damage. This repair defect makes individuals with XP highly vulnerable to UV radiation, leading to an increased risk of skin cancers such as basal cell carcinoma, squamous cell carcinoma, and melanoma, as well as neurological complications like progressive cognitive decline and hearing loss. In addition to these risks, sun exposure accelerates DNA mutations, significantly increasing the likelihood of cancerous changes in skin cells. As a result, individuals with XP must take extreme precautions to avoid UV exposure. These measures, while crucial for reducing the risk of skin damage and cancer, have unintended consequences for vitamin D synthesis. Since vitamin D is predominantly obtained through sunlight, patients with XP are at a high risk of developing vitamin D deficiency unless they receive adequate supplementation through diet or vitamin D pills. Impact of vitamin D deficiency on bone density. In patients with XP, the lack of sufficient sunlight exposure can lead to an insufficient intake of vitamin D. This deficiency can have profound effects on bone health. The most immediate concern is impaired calcium absorption, which may lead to hypocalcemia, low blood calcium levels. Hypocalcemia triggers secondary hyperparathyroidism, compensatory response in which parathyroid hormone, PTH, levels increase in an attempt to maintain calcium homeostasis. Elevated PTH levels cause increased bone resorption, which over time can lead to bone demineralization, reduced bone mass, and increased fracture risk. The clinical manifestation of this can vary depending on the severity and duration of the vitamin D deficiency. In children, the consequences may be more pronounced, resulting in rickets, characterized by weakened, soft bones that can deform, particularly in the weight-bearing limbs. In adults, the deficiency may lead to osteomalacia, a condition where bones become soft and brittle due to defective mineralization, increasing the risk of fractures. Patients with XP are at an elevated risk for these bone-related complications due to both their sun avoidance behaviors and the genetic nature of their disorder. While vitamin D supplementation is a critical management strategy, achieving sufficient levels can be challenging. The difficulty in absorbing vitamin D through diet alone, combined with the potential for other metabolic disruptions, means that careful monitoring and tailored treatment strategies are essential. Management strategies for bone health in XP patients. Managing vitamin D deficiency in patients with XP requires a multifaceted approach that includes both supplementation and monitoring. Given the inherent difficulty in obtaining sufficient vitamin D from sunlight, primary strategy involves oral vitamin D supplementation. The goal is to maintain serum 25-hydroxyvitamin D levels within the normal range, typically between 20 to 50 nanograms per milliliter, depending on individual health circumstances. High-dose vitamin D may be required in some cases to compensate for the lack of sunlight exposure, especially in pediatric patients who are still growing and developing bone mass. However, supplementation must be approached with caution, as excessive doses of vitamin D can lead to toxicity, resulting in hypocalcemia, high blood calcium levels, which can have detrimental effects on the kidneys, bones, and heart. Therefore, regular monitoring of serum calcium and phosphate levels is crucial to ensure the safe and effective use of vitamin D supplements. In addition to supplementation, dietary strategies to boost calcium intake are also important. Calcium-rich foods, such as dairy products, leafy greens, and fortified non-dairy alternatives, e.g., almond milk, can help support bone health. In some cases, calcium supplementation may be recommended, particularly for individuals who have difficulty meeting their calcium needs through food alone. Exercise also plays a critical role in maintaining bone density. Weight-bearing exercises, such as walking, resistance training, and jumping activities, help stimulate bone formation and maintain bone strength. However, patients with XP must balance the benefits of physical activity with the risk of UV exposure. Exercise indoors or during times when UV radiation is minimal, such as early morning or late evening, can be a safe way to engage in bone-strengthening activities. In some cases, especially when bone loss is advanced, bisphosphonates or other pharmacological treatments that inhibit bone resorption may be considered. These medications help preserve bone density by decreasing osteoclast activity, reducing the rate of bone loss, and improving bone strength. Challenges and future directions. While managing vitamin D deficiency in XP patients is essential, it is not without challenges. Vitamin D supplementation alone may not fully compensate for the complex metabolic disruptions present in individuals with this condition. Genetic variability, variations in response to supplementation, and potential interactions with other medications add layers of complexity to treatment regimens. As research into XP and other rare metabolic disorders advances, more targeted therapies may emerge, potentially offering more effective solutions for managing bone health in these patients. Moreover, increasing awareness of the importance of bone health in sun-sensitive conditions like XP is vital for both clinicians and patients. A holistic, multidisciplinary approach to care, integrating dermatologists, endocrinologists, geneticists, and nutritionists, can help ensure that these patients receive comprehensive management strategies for both their skin cancer prevention and bone health needs. Conclusion: vitamin D deficiency presents a significant challenge in individuals with rare metabolic disorders such as Xeroderma Pigmentosum, which requires strict sun avoidance. The effects of vitamin D deficiency on bone density can lead to a variety of musculoskeletal issues, including osteoporosis and fractures, if not carefully managed. Ensuring adequate vitamin D levels through supplementation, dietary changes, and lifestyle modifications is crucial for mitigating these risks and maintaining overall health. With ongoing research and a coordinated care approach, it is possible to address the challenges of sun avoidance and vitamin D deficiency in rare metabolic disorders and improve patient outcomes.